Good afternoon. This is Lauren Dunlap, Executive Director for Advocacy and Awareness for Immune Disorders Association, or AAIDA, in Charlotte, North Carolina, and I'm happy to host this afternoon's webinar. AAIDA's mission is to provide support and advocate for the greater than 25 million Americans living with immune disorders. AAIDA works to promote research and create better awareness of immune disorders. This is AAIDA's 9th webinar for 2022, and today I will be joined by pediatrician and rare disease consultant, Dr. Ashok Gupta. Dr. Gupta is a practicing pediatrician at SMS Medical College in Jaipur, India, and chairman for the Rare Disease Division and Pediatrics. Dr. Gupta is also chairman of Allergy Care India and current board member of the Global Allergy and Airways Patient Platform. Dr. Gupta, thank you so much for joining us today.
Thank you, Lauren, for your kind words of introduction.
Very excited to have you be a part of AAIDA today and looking forward to today's presentation.
It's my pleasure because this is coming from a different part of the world, and I just felt that yes, some of these things post-COVID have been almost common to the world, that one needs to understand that it's not an isolated event, it is a global event, and things have affected the people all over the world. And so I was really keen to be getting on to AAIDA's activity and event, and so that trying to make communication with the other world to say yes, these disorders following COVID infection or COVID vaccination have been seen extensively in most parts. So if you permit, I go ahead with my presentation.
Perfect.
Okay. So what is important is following COVID, what had happened was we have seen a large number of cases, one primarily COVID disease related serious cases. Then we saw some of these cases who manifested multi-system inflammatory syndrome. Then there is another interesting group who, following COVID vaccination, had a flare-up of their autoimmune disorders. And then there's still another group where some of these very rare autoinflammatory disorders, which we normally never saw in this part of the world, suddenly started manifesting. And that's exactly where I realized it is very important today that to understand the impact of COVID on the human race. It's just not only the COVID disease, because if you look at the COVID disease, the spectrum is from absolutely asymptomatic individual to mild disease to a very severe disease. So this was the kind of spectrum that the world experienced. And based out of that spectrum, we thought that any viral disease, it ends after the viral infection gets over. But it turned out to be something different in this case, because we started analyzing the data. The institution that I head, it's one of the biggest pediatric hospitals of the country. We have 1,000-bedded pediatric hospital, and it's a tertiary care center of the state, and that's where you get all complicated patients. And so over a period of 6 months between January to June 2021, we had 180 patients who were diagnosed with multi-system inflammatory syndrome. And these are those cases who completely got or who would fit the diagnostic criteria. And the management plan, because it took us a while, because such cases were being reported from the world literature as early as 2020. So by the time we really started managing these patients, we were fairly informed, and thus the mortality rate, what we saw in our institution, was not very high. It was just 5.5% of all the patients. 2% of these patients went against medical advice, and over 92% were discharged and safely sent home. And they have all been followed for a long COVID phenomenon. 36% of these patients required intensive care management, and all these patients had inflammatory markers which were elevated. And the two inflammatory markers that we focused on was C-reactive protein and interleukin-6. And thus, if you look at the spectrum of these patients who came to us, we had almost 11% who presented with shock or a multi-organ dysfunction. And then we had almost 20% with Kawasaki disease type manifestation. Then there's another group which had febrile inflammatory syndrome. And then we had almost 5% who were not typically classified. But the fact is that most of them had evidences of autoinflammatory disease and had elevated interleukin 1 or interleukin 6, and they also had evidences of elevated C-reactive protein. So what I was trying to make you understand is, yes, the COVID disease produced primary complications secondary to multi-system inflammatory syndrome. And in my subsequent slides, I'll also take you through why this virus has been different than the other viruses. And what was very important is that the need for inflammatory markers for assessing the multi-system inflammatory syndrome and active COVID diagnosis made them more widely available at various centers. So the logic that why we have been able to pick up more cases was because the diagnostic facility became more easily available, and thus we were able to help identify various other conditions with similar pathogenesis or similar cytokine storm, and thus it also led to broadening horizons for cases that were never explained by the multi-system inflammatory disease. And it also brought to light a lot of such rare disorders, which included immunodeficiencies, complement deficiencies, primary HLH, and autoinflammatory syndromes. And some of those rare representations of common disorders like scrub, tuberculosis, SLE, and dengue. And I would take you through some of our interesting cases seen at our center. Darshika was a 6-year-old.
Just right quick, because of our audience is so vast and different in their knowledge, would you just tell our audience members what CRP, the C-reactive protein, is,
Okay.
and how important that is in inflammation markers? You want to just touch on that real quickly so they understand?
Yeah. The C-reactive protein is a marker of inflammation, and marker of inflammation which is being produced by the presence of any whenever you have inflammation in the body, the inflammatory markers, that is interleukins, are the first to come, and then interleukins are followed by the C-reactive protein. It has a half-life of 6 hours, so that once the inflammation is over, the C-reactive protein rapidly disappears from the human blood. Then the interleukin 6, what happens is, even with COVID disease, what the COVID virus does is it stimulates the endothelial cells and produces reactive oxygen species. And reactive oxygen species are responsible for stimulating the inflammatory markers, and especially they result in the synthesis of caspase 1, which converts the pro-interleukin 1b into interleukin 1b. So interleukins are inflammatory markers, and inflammation, when the inflammation in the body starts, these inflammatory markers are responsible for, these cytokines are responsible for the initiation of inflammatory cascade. And inflammatory cascade is measured by the various parameters like erythrocyte sedimentation rate or the C-reactive protein. So, and then if you have a secondary tissue damage following the inflammation across the body, you can have certain liver enzymes that go up, or you have some abnormality in the renal functions, which can be measured by doing renal function tests. And thus, the markers have to be understood, and these give you a clue to the possibility of the disease. So this was a 6-year-old.
Thank you for that explanation, Dr. Gupta, on the CRPs.
And so one of the first cases that I would like to present is a 6-year-old child who came to the hospital in February 2022 with complaints of high-grade fever for 15 days, maculopapular pruritic rash for 10 days. Then we had the child had arthralgia, means pain in the joints, and this was present in multiple large joints. And later on, it also involved the small phalangeal joints for almost 10 days and had a migratory pain, though she was absolutely symptom-free till January, and when she developed all these manifestations. January 21, she had fever, rash, and arthralgia, and a history of COVID contact. And thus, she was treated as a case of multi-system inflammatory syndrome, because if you look at the parameters as shown in January 21, you had the total leukocyte count, that's the white blood cells, which were elevated, the neutrophils were high, and the C-reactive protein that I told you earlier again was, which should be usually less than 6, was as high as 95. The ESR again was high, and the COVID antibody was reactive. So it looked very simple, and the diagnosis was kept as MISC. But however, again in August 21, the child came with fever, with pruritus, rash, and arthralgia. Now you see what is happening is you have these antibodies being produced, and it's a very simple thing that whenever we have infection in the body, the infection, when it goes inside the body, it's known as it is an antigen, and an antibody is created against that invading organism, and the antibody destroys or tries to restrict the organism. But however, because of the COVID, what had happened was the immune system got derailed, and the result was any antigen that got into the body would produce uncontrolled antibodies. So when you have these uncontrolled antibodies, that is the antibodies beyond what you require in the body to contain the infection. Now, these antibodies then subsequently start damaging the body itself. And that's what is autoinflammatory disease. And thus here you had a child who had contact with COVID, positive COVID antibodies, and we thought the diagnosis is so simple, MISC, and we treated the child appropriately. But however, if you look at over a period of 6 months, again the child develops manifestations with fever, rash, itching, and joint pains. And so we thought that this is probably something like an immune compromised state, and put the child on anti-tubercular treatment, because tuberculosis is still seen here in this part of the world. But however, following the anti-tubercular treatment, there was no response, so we discontinued it. And now this child again comes to us in February 22 with fever, rash, and joint pains. So a possibility of TRAPS, that's another autoinflammatory syndrome, was kept. And all along, if you look at the C-reactive protein, it is consistently elevated. And the ESR is also consistently elevated between January 21, then August 21, and February 22. So inflammation is continuously present with leukocytosis, that's increased white blood cells in the body. And the tuberculosis test for tuberculosis turned out to be negative. And in February 22, the investigations focused on looking for evidence of inflammation. A D-dimer test was done. D-dimer is indicative of ongoing intravascular coagulation. So that was found to be positive. And we also measured the immunoglobulins in the baby, which were found to be normal. And the bone marrow examination again was normal, and a whole exome, that is a genetic analysis, was done. And because the presentation gave us a thought that this is some kind of autoinflammatory syndrome, we did not have the exact diagnosis. So we still put the child on intravenous immunoglobulins. And because the principle of management in children with autoinflammatory syndromes is to contain the inflammation. That is, contain, because if it is interleukin-1 mediated inflammation, we use anti-interleukin-1. And if it is interleukin-6, we use anti-interleukin-6 drug. So this is only to contain the ongoing inflammation, suppress it, and gradually the patient's body will take care of the issues. And so when we gave IVIG, we did find an adequate response. And so this child was started on tocilizumab, that is an anti-interleukin-6 inhibitor, interleukin inhibitor, and the patient improved symptomatically and biochemically also. And then this child was referred for the whole exome sequencing was sent, and what we realized was the child was identified having a mutation which was suggestive of immunodeficiency 40. Now, this is why is it important to understand is here you have a child who starts with COVID antibodies and finally is being diagnosed as immune deficiency disorder. And immune deficiency disorder, because that's exactly what I said in the initial phases. We have seen cases who were probably latent. They would have never manifested disease, but the COVID exposure brought in an initiation or identification of the disorder, and thus now you have a diagnosis of this patient as immune deficiency disorder, the immune deficiency 40 also recessive, and has been referred for hematopoietic stem cell transplant. There's another interesting case. Was a 4-year-old child, female child, born out of a second-degree consanguineous marriage, was referred to us from a hospital. Then the child had prolonged fever, was under evaluation. January 21, fever, rash, joint pains, again COVID history, contact history. So was treated as a case of multi-system inflammatory syndrome. Then April 21, the child developed fever, rash, arthralgia, erythema of palms, soles with urticaria. And because if you look at the Kawasaki manifestations, they would normally have fever, rash, conjunctival congestion, and desquamation of the skin. So you had erythema of the palms and soles, presence of urticaria, fever, and rash. So it was thought to be Kawasaki disease, was given intravenous immunoglobulins. And again, in September 21, the child comes to us with the same manifestations of fever, rash, and arthralgia. So that's exactly what is happening, that you continue to have antibodies being produced uncontrolled and unchallenged. And the net result is you are getting children getting into autoinflammatory syndromes. So again, here the whole exome was sent and the child was put on steroids. And the investigations, if you look at the investigations again, between January, April, and September of 2021, CRP, that is C-reactive protein, continues to be high in all the three situations. And the child continues to have increased leukocyte counts, increase in the WBC counts, which is again an indicator of active inflammation. And interleukin 6 again was found to be elevated, and COVID antibody was found to be reactive. So you have an individual again who had a COVID exposure, and COVID exposure resulted in antibodies, and antibodies now are proliferating uncontrolled, and thus the manifestations of autoinflammatory disease are there. In November 21, again, the child was presented to us with fever, rash, and was on steroids. Again, we gave anti-interleukin injection, tocilizumab, and December 21, the child was put on tocilizumab 3-weekly planned treatment for autoinflammatory disorders. So child was symptomatically better on tocilizumab with fever, still recurring every 3 weeks, but rash and joint pain were controlled till October 22. And again, the markers of inflammation are high, then the ESR is elevated, and then a whole exome sequencing was done for this patient, and the child turned out to be complement 4A deficiency. So this is complement 4A deficiency. Again, that's what I'm trying to again emphasize. These are the patients who would never have would have manifested disease. They have manifested disease because they were exposed to COVID. And now, because some of these injectables we never have used in our medical management. I've been into practice for almost 35 years and never used tocilizumab and other drugs so often. And this child in October of 22 came to us with continuous fever, and despite being on regular tocilizumab, and the child also developed a new onset ankle pain and swelling, anemia, ANA was positive, and the patient also developed hair loss, alopecia. And now we had a thought of revisiting the diagnosis, and we used the EU-LAR criteria of SLE, and anti-TPO antibodies were sent. And what has been found that C4A deficiency patients are higher, predisposition to develop autoimmune disease. And so they were now, this child is now been started on steroids and methotrexate. And fever, pain, and ankle swelling have all responded. So this is a lot of learning has happened in the past 2 years. And now we understand that early diagnosis based out of whole exome would given us a much better chance to treat them with the most appropriate or targeted therapy than what we have been doing as a standard protocol of basing our diagnosis and presumptively and moving on treating these children. Another case is a 2-year-old male child, again of non-consanguineous marriage. He was asymptomatic till 1 year of age. The first thing that he developed was pneumonia, and in July of 2022 was admitted with fever, cough, and bilateral non-exudative eye discharge. Parents were positive for COVID, and after 1 week of fever, the child developed ear discharge. And again, because the clinical manifestations do match the spectrum of multi-system inflammatory disorder, especially the Kawasaki-like presentation. So the child was treated with oral methylprednisolone. So May 21, the child has been treated with IV antibiotics because pneumonia was the diagnosis and was given symptomatic management. The inflammatory marker C-reactive protein was significantly elevated, and the COVID RT-PCR was positive. So the child had a positive test for COVID, not the antibody. And then in July of 2022, that's almost a year, almost 15 months later, the child develops fever, cough with bilateral non-exudative eye discharge, ear discharge, and parents are COVID positive. And based out of this presentation, a diagnosis of multi-system inflammatory disease was made, and an oral methylprednisolone was started. The markers, as shown in the laboratory investigations, clearly give you a clue to the possibility, because C-reactive protein is high, interleukin-6 is high, and D-dimer is again an indicator of consumption coagulopathy is high, and the bus culture was sterile. So between 1 year and 6 months, the child had fever and diarrhea. 1 year and 10 months, fever and ear discharge. And at the age of 2 years, the child had fever plus ear discharge with elevated C-reactive protein. And then IgG, IgA were low, and a whole exome was sent due to recurrent infections. And the differential diagnosis kept was the severe combined immunodeficiency or an X-linked A-gamma globulinemia. These are two immune deficiency disorders where you have, when you say X-linked A-gamma globulinemia, that is the patient doesn't have the immunoglobulins which are responsible for protecting us. And the second is the severe combined immunodeficiency, again, is an indicator of absence of immunoglobulins. So the whole exome which was done suggested of X-linked gamma globulinemia, and now the child has been put on monthly intravenous immunoglobulins, and the child is doing well. So
Dr. Gupta, I had a quick question around this specific case. When you use SCID, severe combined immune deficiency, and the XL A-gamma globulinemia, because he was not diagnosed prior to him having the symptoms, correct? He wasn't diagnosed before then?
No, yeah, he was never diagnosed before that. That's exactly what I'm trying to say.
Right.
If you look at the approach, and our experience makes us understand that you need to move on to the whole exome analysis much before. You should not waste so much of time and as a final resort looking onto this investigation, because all the three cases I'm already putting here, the diagnosis has been made or has been confirmed by the genetic analysis. So the genetic analysis in any case which is slightly difficult to treat, or you're not sure with the diagnosis, genetic analysis should be made much earlier than as the last one.
Well, yeah, and that was what was interesting to me because here in the US, it was only in the last maybe decade, maybe the last 10 years, that now newborn screening has been implemented in all 50 states around severe combined immune deficiency. And I just
Yeah.
wasn't sure if India had the tools and resources available to screen those newborns for that specific
No,
condition,
no,
since it
no,
is
no.
still.
In India, we still do not do a newborn screening for this kid because I was planning to do it as a pilot project because in India, even the newborn screening is still not universal. So unless you need to develop a universal newborn screening program and especially strengthen ourselves with the basic maybe 6 or 10 disorders and then gradually build on it because it cannot happen in on just in a very short phase, but we
Mhm.
need to sensitize and make people understand. And that's where, because I was one of the first few in the state to launch a newborn screening program in my own institution. And we have done almost 30,000 newborn screens and have been able to pick up more than 120 uh, children suffering from some of these disorders. So it's
Congratulations, that's amazing.
yeah, it's been a fairly successful program, and I totally agree with the thought that state and other things you need to pick them early, and that is again one of the things that has come up with my experience on these patients, that you need to make a diagnosis or use a genetic test before, and not keep it as the last resort.
Mhm.
So this is just to say this is the kind of overlap that you see between Kawasaki and CV COVID and MISC. It's slightly more technical, it doesn't make sense for us to discuss this. And then there's another interesting study that has come up was this is autoinflammatory disease with immunosuppressive therapy, because most of these patients who have had experienced COVID-19 were put on immunosuppressive therapies, and we are trying to understand the expression of autoinflammatory disease. And so, and because of what I said about COVID-19, the disease increases the interleukin-1 beta release, and because anti-interleukin-1 treatment is effective in interleukin-1 mediated autoinflammatory disease. And so in this case, it is what has been presented from a group of people, Samuel and Jana. These people, what they clearly identified that they had a 34-year-old woman who mediated who with an unclassified autoimmune disease and so was treated with and methotrexate therapy, because this was on immunosuppressive therapy, developed an unclassified autoimmune disease. And then some other individuals who turned out to be positive for cryopyrin-associated periodic syndrome, and they have very specific therapies for that. So this again just gives you a clue that COVID-19 influenced the endothelium and produced reactive oxygen species, which activated the NLRP3 inflammasome. These inflammasome, this is just a small technical component, resulted in the synthesis of caspase-1, and caspase-1 was responsible for conversion of pro-inflammatory means pro-IL-1 to IL-1, that's active form of interleukin-1, and then there is then they initiate the inflammatory cascade. So it's just to say that immunosuppressive treatment has been associated with autoinflammatory disorders. So this is just the schematic presentation of what actually is happening. So COVID-19, reactive oxygen species, and all this, which I've already told you. And the net result of all this is, because it also, the reactive oxygen species also stimulates NFKB, and they all result in the release of cytokines and inflammatory cascade. Then there's another interesting thing that has happened, which I said was a group of disorders which were directly linked to COVID and multi-system inflammatory disease. Then you have another group of disorders which were otherwise not manifest, became manifest, And now you have a third group of disorders where you have autoimmune and autoinflammatory conditions after COVID-19 vaccination. And because what has happened is these vaccines, after they were introduced, they have been shown to produce some of these cases and the most common diseases that have been associated, or especially with the new onset events following vaccination, were ITB, that's immune thrombocytopenia, or you have myocarditis, or you have the Guillain-Barré syndrome. And so, and in contrast, immune thrombocytopenia, psoriasis, and IgA nephropathy, and systemic lupus erythematosus were the most common illnesses associated with relapsing episodes. And the first dose was linked with new onset of events, whereas the second dose was related to the relapsing disease. So that's another group of disorders that we have been able to understand that COVID-19 vaccination has been has resulted in some of these things.
Dr. Gupta, is it for our audience members to better understand what you're referencing? Is it almost like these patients have their predisposition to developing this? It's kind of like they're lying under the surface, right? And then when COVID came or the vaccination came along, it made their system potentially develop these conditions because they had a predisposition in the first place. Is that correct?
No, I think there are two things that you're concerned. With the first dose of the vaccine, the diseases that manifested were the new diseases like immune thrombocytopenic purpura or myocarditis. They were there for the first time. But with the second dose, it was relapse of the previously existing autoimmune disease. For example, if somebody had IgA nephropathy, it relapsed. For example, optic neuritis, this relapsed. Or you had juvenile rheumatoid arthritis, this got flared up. So, so you have autoimmune hepatitis that got flared up, and so this was another thing that happened. So we have to be very, very cautious, very understanding on what has been the larger impact of COVID. It's not only the virus itself producing a disease, it also has influenced, the vaccine has influenced the occurrence of some of these autoinflammatory or autoimmune disorders, producing a relapse in some of them, and also producing a newly diagnosed disease in some of them. So it's been both. It's not always in a pre-existing disease. So this is another case of skin lesion which appeared 9 days after vaccination. And these are the painful erythematous plaques of various sizes, and they were scattered on the four extremities, and skin biopsy and histological findings clearly gave you a clue to the diagnosis. So this was one of the manifestations, what's known as the sweet syndrome following vaccination. Then there was another disorder which is the seen after 7 days of vaccination, that's vasculitis. And this is again an erythematous lesion with a pale center through pruritus and distributed on the trunk and extremities. And skin biopsy and histological finding did support the diagnosis. So this was one of those things that also came up following vaccination. So that's something which was very, very, it's something new to understand, that vaccine can produce a disorder, and the disease itself can produce a disorder, and the disease itself can bring in or manifest some of the latent disorders. So it's been a different experience even in India. That's something that I just wanted to highlight, and maybe this is probably true across the world. So do we have time now?
Yeah, we're good. Go ahead.
Yeah. So if we have time, I'll just try to take you through multi-system inflammatory syndrome in children. That's we have had different definitions coming from the Royal College of Pediatrics, then Center of Disease Control, CDC, US, and World Health Organization. But overall, it is usually seen in children and adolescents. Would come as fever with multi-system organ involvement and elevated markers of inflammation and evidence of COVID-19. And one thing important was some of these individuals may fulfill full or partial criteria for Kawasaki disease. But even if they do not have those criteria, then people were asked to report it. And the Kawasaki disease manifestations, it's based out of the presence of 4 of at least 5 of the manifestations that were supposed to be there. One is erythema and cracking of lips, strawberry tongue, or erythema of oral and pharyngeal mucosa, bilateral bulbar conjunctival injection without exudate, presence of rash, maculopapular diffuse, erythroderma or erythema multiforme like manifestations, then erythema and edema of the hands and feet in acute phase or periankle desquamation in subacute phase, and presence of cervical lymph gland more than 1.5 centimeters, usually unilateral. So that's where you put in a possibility of Kawasaki manifestation following COVID as part of your multi-system inflammatory disease. And then there were other criteria that we also use for multi-system disorders in children. And this included the age between 0 to 90 with fever of more than 3 days, and at least 2 of the following: rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation, hypotension or shock, and features of myocardial dysfunction, especially pericarditis, that is cardiac involvement or valvular involvement, and coronary artery abnormality, including echo findings or elevated troponin or pro-BNP. Evidence of coagulopathy in the form of elevated D-dimer or elevated prothrombin time or deranged partial thromboplastin time, and acute gastrointestinal problems with diarrhea, vomiting, or abdominal pain. And you have need to have elevated markers of inflammation such as the ESR and the C-reactive protein or procalcitonin. And additionally, no other obvious microbial causes of inflammation, including bacterial sepsis, staph, or streptococcal shock syndrome. And finally, evidence of COVID-19, that is either you have a RT-PCR antigen test which had to be strongly positive or likely contact with patient with COVID-19. So autoinflammatory syndromes, and if you look at the spectrum, we have the GAAPP clinical spectrum from NOMID to MWS to FCAS. These are all various manifestations of the multi-step pathways of interleukin-1B mediated inflammation. So it's only one single interleukin mediated inflammation. And if you look at the picture, it clearly gives you how the caspase gets, caspase 1 gets stimulated, and how does it convert the interleukin, makes interleukin 1, pro-interleukin 1B to active interleukin 1B to initiate the inflammation inside the body. There are a large number of autoinflammatory syndromes that we have now been able to diagnose and see, and that's because what I said in the initial slides, that now since we had the facilities to investigate inflammatory markers and genetic analysis, we were able to identify quite a few of these autoinflammatory disorders. And just to enumerate some of them, one is hereditary febrile disorders. One is your familial Mediterranean fever. The drug of choice for this is colchicine, and the alternate drug is anakinra or rilonacept. And then the other is the second hereditary fever disorder includes TRAPS. The treatment would be non-steroidal anti-inflammatory drug or anakinra, and an alternate drug would be steroids. There's another disorder that we experienced was hyper-IgD syndrome with periodic fever. Again, the drug of choice is anakinra with non-steroidal anti-inflammatory drugs. And an alternate drug included canakinumab or etanercept or steroids. Then we have the CAPS. The group of CAPS include the FCAS, which is FCAS or MWS and NOMID. They all three would respond to the drug of choice is anakinra, and the alternate drug is rilonacept or canakinumab. And then there are certain other hereditary disorders like pyogenic arthritis, pyoderma gangrenosum, and acne. Anakinra is the first line, and steroids is the second line. The Blau syndrome is corticosteroids, anakinra, and deficiency of interleukin-1 receptor antagonist. Again, anakinra, and the second line is canakinumab and rilonacept. And then another disorder is pseudo-gout. The first line drug is anakinra, and Second line is etanercept. Then, just to give you a brief outline, that there is a large number of monogenic autoinflammatory disorders, and monogenic autoinflammatory disorders include the familial Mediterranean fever, TRAPS, ITS, and GAAPP. And then they've also been given the therapy and the level of the strength of recommendation that's available. For example, for familial Mediterranean fever, colchicine has a very good evidence 1B/1A, whereas again TRAPS again has fairly good scientific evidence to say the first line management, and so this is true with most other autoinflammatory disorders. And then as the science has evolved, now we have the second line drug and third line drug for all different level of dysfunctions seen in these autoinflammatory disorders that are not responding. Many drugs which are still under trial, and we have one of them which is first in the human single center double-blind randomized crossover study of IZ-334. It's a small molecule inhibitor of NLRP3 inflammasome. This is one of those inflammasome which is very, very important mediator of cytokine storm. And then there's another one is IZD-174, a small molecule inhibitor of the NLRP3 inflammasome. So the focus is to control NLRP3 inflammasome so that, yes, you are able to take care of the cytokine storm at the first initial phase before even the interleukins are being produced. So that's the kind of scientific evidence and scientific activity that's happening. And if you have any questions, I'll be very pleased to answer.
Thank you, Dr. Gupta. That was very enlightening presentation. I did have a question going back to your third case with the 2-year-old with severe combined immune deficiency or SCID. So he was diagnosed with X-linked gamma globulinemia and SCID at age 2 years old. This was interesting to me simply because the babies born with SCID generally don't live very long after they're born, only a few months until newborn screening was implemented in the United States. So this was actually kind of fascinating for me since SCID is a primary immune deficiency disease, and how this particular child lived to be 2 years old without being diagnosed until he was at 2. So it seems pretty long time for that.
Yeah, I think what you need to understand is the inheritance again is a very complicated chapter. So inheritance means there are always the gene mutations which are responsible for the expression of the manifestations. Now, if there is some partial manifestation happening, so the net result would be qualitatively the diagnosis stays as SCID or X-linked gamma globulinemia. But what happens is they still continue to have some degree of immune support, and thus they are able to survive. So there is a lot of variation in individual patients too, and I believe that was one of the reasons that the child survived, because in the first 6 months they are passively transferred the antibodies from the mother, which sustain the baby, and it's only in the second 6 months when this serious infections keep on happening. And as chance would have been, the parents brought the child very regularly for treatment, and that's why infection they were able to get the infection getting treated every time. So
it's been very interesting to watch COVID because you have primary immune deficient patients such as myself. They're all rare genetic defects in the immune system, and then you have a group, of the secondary immune deficiencies. So it's almost like, well, these patients that you're now seeing, they don't fit into either category. It's almost a type of third immune deficiency in a way, because they're predisposition to it when they're born, but they also develop it later. So I was just wondering what your thoughts on that were. Is there a potential that there could be a different classification of immune deficiency or antibody autoinflammatory, syndrome cases? Or I don't know. I don't know what that looks like. I just was curious as to hear your thoughts on that.
No, I totally agree with you because this was something very new to us also because all these years we never really had that kind of perception that something can trigger means a spurt of autoinflammatory phenomenon in different in people with different backgrounds in terms of genetic inheritance, and thus some of these disorders which were never manifest earlier, they certainly became manifest. So I believe because my own study, I think we have identified more than 200 autoinflammatory patients. So now, and this is all because the body's immune system has been disrupted extensively, and I'm getting patients who just come to me with prolonged paralysia. There's been a very significant shift in the kind of disease pattern that we are seeing, and this shift in the disease pattern includes that now patients who come to us do not have a standard viral disease lasting for 3 days or 4 days. You have a viral disease which gets into the body and then it continues for 10 days, 14 days, 15 days, which is something which never happened in the past. So I believe there's been a major impact on the human immune system, and we need to have more papers and more scientific work in this area before something can be said authoritatively. But that's an observation that the immune modulation or autoimmune disorders, or what you say is autoinflammatory diseases, they have all become more common than what they were in the past.
Yes, I totally agree with that. I did want to also go back to, you touched on Kawasaki's disease, and I just wanted to take a moment to educate our audience around what Kawasaki disease is. Generally speaking, in general terms, is it's diagnosed in childhood, and since COVID, the clinicians have potentially seen an increase in this rare condition. However, now that we're almost 3 years deep into the pandemic, they're realizing it's actually not Kawasaki's disease that they are seeing an increase in. It's almost a type, it's like Kawasaki's disease, but it's actually not. Is
Yeah,
that my understanding?
yeah, I totally agree with you. It's not Kawasaki, but it's Kawasaki-like disease, and that's the reason it is said that Kawasaki-like manifestation of multi-system inflammatory syndrome. It's not Kawasaki disease. Kawasaki disease is seen based out of a gene mutation in the body, but here it is not a mutation. It is a clinical manifestation which simulates Kawasaki disease in a child who has evidences of multi-system inflammatory syndrome following post-viral COVID exposure.
And the treatment is pretty similar with
Yeah,
IVIG for those patients.
yeah, but what I showed you that IVIG was not, we were not able to get responses from IVIG alone, and that is where we had to use an anti-interleukin injection in most of these patients because again the manifestation looks similar, but the underlying disease is different, and that's why we had to use the anti-interleukin drugs, which we normally don't use in Kawasaki. Kawasaki, the first line therapy would be IVIG, and then there's usually a maintenance therapy with aspirin. So these patients, when they did not respond, the point it also highlights the same thing. It's not Kawasaki; it's Kawasaki-like manifestations.
Right. No, I just wanted to clarify that for our audience members who may have
Yeah.
heard that various information, and just want to clarify. Now, when you are have the interleukin injections, how long generally are these patients treated with that?
Yeah, the inflammations actually because they've been a variable period for which their inflammatory markers have been elevated, and so but anywhere between 6 months to 1.5 years that we've used anti-interleukin injections.
That's, okay. And the other question was, I wasn't ever sure if you had seen any of these types of patients or you were familiar with the PANDAS or PANS patients with autoimmune encephalitis. And do you ever treat any of those patients pre-COVID in your clinic, or are you familiar with that diagnosis?
Autoimmune encephalitis?
Yes.
Yeah, yeah. We treat a lot of autoimmune encephalitis, and for them, we do a CSF antibody assessment, and the drug of choice is methylprednisolone. And the success rate with the therapy is usually not very great. Yeah, but we see because these are usually means they are all antibody-mediated autoimmune disorders, and by and large, yes, our success with autoimmune encephalitis has never been very good.
All right. Let's see, I think that was all the questions.
Thank you.
So, Dr. Gupta, thank you so much for being with us this afternoon and volunteering your time to educate our community across the globe. And thank you to our audience for tuning into this afternoon's presentation. Don't forget to register for our next webinar, which is on January 25th, and it's with Dr. Jennifer Casado from 4 o'clock to 5 o'clock Eastern Time, and it's really on climate change. This would be very interesting. This is Lauren Dunlap for Advocacy and Awareness for Immune Disorders Association, and we hope you have a fantastic afternoon. Thank you.